Let's jump right into this explainer. Today, we're tackling something you'll see all the time in the clinic, yet it remains a completely fascinating anatomical mystery. We are talking about the ganglion cyst. We're going to put on our medical detective hats and figure out exactly what it is, how it forms, and as future or current clinicians, what we should actually do about it. Picture this. A patient walks in, and they've just discovered this distinct, prominent lump right on the back of their wrist. Naturally, they might be panicking a bit. What exactly is it? Is it dangerous? And more importantly, what's our clinical game plan? Well, as you'll see, the answers are both reassuring and highly intriguing. To crack this case, we're going to follow a strict clinical workup. First, what is a ganglion? Second, the pathogenesis explained. Third, identifying clinical features. Fourth, differential diagnosis. And finally, treatment and recurrence. Okay, Section 1. What is a ganglion? Let's define the mystery. Fundamentally, a ganglion is a fluid-filled sac. The strict clinical definition describes it as a cystic swelling occurring in relation to a tendon sheath, a synovial sheath, or a joint capsule. In plain terms, it's tied directly to the moving parts of the joint. And inside this localized balloon, you won't find blood or solid tissue. Instead, it's filled with a very distinct, clear, gel-like fluid. So, where do these things prefer to hide out? By far, their absolute favorite location is the dorsum of the wrist, right near the scaphoid lunate articulation. But if they aren't on the back of the wrist, you'll sometimes find them on the flexor aspect, the palm side. And occasionally, though it's less frequent, they'll pop up right around the ankle joint. Let's move to Section 2, the pathogenesis explained. Time to break down the biology. The biological origin story follows a highly specific timeline. Step 1. It begins with cystic degeneration of the tendon sheath. This is essentially a localized breakdown or weakening of the tissue. That weakening leads directly to Step 2, which is a microscopic leakage of synovial fluid right through the joint capsule. Finally, in Step 3, this leaked fluid forms small islets of microspaces. Over time, these tiny isolated pools simply fuse together or enlarge, giving us the visible ganglion cyst we see on the skin. All right, Section 3. Identifying clinical features. Let's talk about the physical signs. When you're examining this lump, you're looking for specific features. It presents as a well-localized swelling that feels smooth. It can be soft, or it can feel tensely cystic, kind of like a tightly filled water balloon. Paget's test will be positive. Strikingly, these cysts are typically non-tender, and get this, they're transilluminant. If you take a pen light and shine it directly against the cyst in a dark room, the light literally passes through and glows. That confirms you're looking at clear fluid, not a solid mass. It's also mobile, but that mobility gets restricted if you have the patient contract the underlying tendon against resistance. And honestly, despite how alarming they can look to a patient, actual pain, tenderness, and restricted movement are quite rare. Section 4. Differential diagnosis. We have to rule out the imposters. A good medical detective always considers the lookalikes. You must rule out a lipoma, which is just a benign fatty tumor, as well as a lymph cyst, a sebaceous cyst, or even a bursa. And here's a tricky one. If the ganglion happens to be very small and tense, it can feel rock hard. That means it often gets mistaken for a sesamoid bone or an exostosis, a bony outgrowth. Sorting through these imposters is absolutely crucial in your clinical workup. Finally, Section 5, treatment and recurrence. How do we solve the problem? The golden rule of treating a ganglion might actually surprise your patients. According to the clinical guidelines, an asymptomatic ganglion is better left alone. Literally, if it isn't causing pain and isn't restricting movement, the best primary medical advice is to do absolutely nothing. And the reason we heavily lean toward leaving them alone comes down to this one glaring number, 30%. There is a massive 30% recurrence rate, even after professional surgical removal. That is a nearly 1 in 3 chance that after the patient goes through the trouble, the expense, and the recovery of surgery, the exact same cyst just grows right back in the exact same spot. Now, if it is causing pain, or if the patient just strongly insists, you can perform an excision, but the protocol is highly specific. It's usually done under local anesthesia using lignocaine plain 2%. You must explicitly warn the patient beforehand about that 30% recurrence rate. Once you remove it, the tissue specimen should always, without exception, be sent to a lab for histopathology. Then, the patient is looking at recovery with a firm crepe bandage applied for a full 4 weeks post-surgery. If a patient wants treatment but wants to avoid the scalpel, there is a middle ground. You might try aspiration. You insert a needle into the cyst to manually drain out that thick gel, flattening the lump out. To help keep that sac from immediately refilling, this is often followed by a sclerosant injection, a medication that basically irritates the lining to scar it shut. It's a very useful, less invasive approach. Okay, I have to share this truly incredible piece of medical history noted right in our clinical texts. Believe it or not, before we had modern sterile surgeries or aspiration needles, people took a much more blunt approach. In the olden days, people used to intentionally rupture these things using a heavy book, most commonly a family Bible. They would literally smash the lump to burst the fluid sac internally. Because of this, they were historically known as Bible bumps. Thankfully, we have much better and way less painful clinical options today, but it leaves us with a totally fascinating dilemma that every patient and their doctor has to navigate. Knowing what we now know about the microscopic fluid leak, the glowing transluminant gel, and that stubborn 30% risk of it coming back, would you recommend excision surgery or advise your patient to simply learn to live with a painless medical mystery on their wrist? I hope this explainer has given you the clinical insight to understand exactly why that's a much harder question than it first appears. Keep learning, and I'll catch you on the next one.